So greetings, everyone. And for those who are still joining us, this first minute or two will just be a quick introduction anyway. But thank you for your interest in the seed grant program and the problem of diagnostic error. I'm not, we've posted FAQs, et cetera, so I'm not going to describe the problem, except to say that our research shows it's the most common, the most catastrophic, and the most costly of all medical errors, and yet one where there has been a real absence of evidence-based interventions. And in fact, even an absence of rigorous consensus measures about how to tally diagnostic errors. We're very thankful to the Gordon and Betty Moore Foundation for their provision of funds to us so that we could create this seed grant program. And our goal is to catalyze innovation. We don't think the answers are known by any means. And as I said, the evidence base for interventions that will reduce the inaccurate or delayed diagnoses of a patient's problem are lacking. And therefore, we have a lot to learn. And through this program, we hope to start that or increase. It started in many places, but we hope to catalyze and increase the things that are being tried and start to build an evidence base. We imagine in maybe 3 to 5 years being in a position to do something like a 100,000 Lives campaign, where we can say these 5 or 6 interventions are evidence-based and will financially and from patient outcome perspective improve healthcare. We've got a long way to go, but this program is part of that. My name's Paul Epner. I'm the CEO and co-founder of CIDM. I'm going to actually step back in a second, just introduce the rest of the people who will be presenting today. Jerry Castro is the Director of Quality Improvement, and he is the overall lead for this effort, so he'll be taking over in just a minute. Jan Magan is a quality improvement consultant who has been with us virtually since the beginning of operationalizing this program, even before Jerry was on board, and so is the bedrock of this program in so many ways. We depend on her expertise and experience in this area. Sue Schrant, who hopefully is on, I'm not sure, she will be on at some point, is CIDM's Senior Patient Engagement Advisor, long history in patient engagement, a critical member of the CIDM staff, and will be also covering how to build patient engagement into your grants, your grant requests. So without further ado, I'm going to turn it over to Jerry, and I'm going to turn off my video and mute my phone. Jerry?
Very good. Thanks for the introduction, Paul, and welcome everybody. It's so exciting to see you all joining here. And as we mentioned at the beginning, as you're joining, your lines are on mute. But if you do have questions, please enter them in the chat using the chat function. It should be located at the bottom and the middle of your screen. Go ahead and introduce yourself, ask questions. We may not get to all of your questions, but we will post those questions online after the webinar. So what we hope to accomplish today is to highlight specific focus areas within the program, the application, point you to some resources, and answer some of the questions that you may have related to the program and the grant process. Throughout the presentation, we'll share some lessons learned from our first cohort of grantees. This is now the second cohort. And then I want to reinforce that everything that is covered today is already included in the documentation that is online. So that's our RFP, the FAQs, and the instructions with the instructions for the online application tool. So let's start with the eligibility for the seed grant program. So there is a lot of text on the screen, but what I want to highlight about the seed grant program eligibility is that it must be a healthcare entity that provides direct patient care. So these are the types of organizations that we have listed in the application, but I will say that it is just that this is the key factor. If there's one thing you take away from this slide, the applicant has to provide direct patient care. So this text is taken directly from our RFP and also contained within our application. But I will also note within the footnote here that organizations that do not provide direct patient care can partner with an organization that does. So that's where the letters of support come in, which we'll cover in just a moment. And then also we make mention of international applicants. They are definitely eligible to apply and receive grant funding. Just within the proposal, you have to describe how this applies to the US healthcare system, and then demonstrate the problem's importance and the intervention's applicability. So let's move on to the next slide. So with regards to eligibility, we categorize by different types of interventions. And so you could, again, this is taken directly from our RFP, but what I will point out is that these represent different stages as far as an intervention is concerned. So we're going from a less well-developed intervention to a more established intervention as you go down the list. So we have a defined problem where you will be developing intervention. So you will have up to 6 months to develop the intervention, or maybe it's a well-defined intervention that you want to test and implement, or it's an implemented intervention that you will evaluate. And then finally, an implemented and evaluated intervention that will be tested in a novel setting or new population. So again, progressively more established intervention is the takeaway from this slide. So those are the 4 types of categories of interventions that we have. As far as interventions of examples, again, this is taken from our RFP and FAQs. The cognitive interventions that we've been seeing are meant to augment, improve, or support clinical decision making. So some of the things we've seen, obviously there's clinical decision support tools, some maybe even dashboards for clinicians to help improve that clinical decision making. The systems interventions around workflow and practice tended to fall into what I would categorized as the closing the loop on test results, or getting the information in a timely way to the clinician when they need it most, to help, or even how to closing the loop on test results for communicating the results to the patient. So those are the types of systems interventions that fall into that category. The educational interventions and the educational interventions tended to be around, educating clinicians, obviously, but what we have as a criteria, or with regards to evaluating these interventions, I should say, we are looking for specific improvements in diagnosis by clinicians that benefits the patients, and then, with a more accurate and timely or communicated diagnosis. So you have to, if you're going to do an educational intervention, you must articulate specifically how the patient will benefit from that improvement. And then finally, the last category here is novel or innovative approaches. So we are always looking for those types of interventions. So non-qualifying examples. So these are, here's the list here, and I'll let you read through them. But the common theme is that we are looking for quality improvement interventions. So they are interventions and not research. Now, the line is blurred and it is a spectrum, right? So we have strict performance or quality performance interventions, and then research, or which tend to fall in my thinking around bench research, or research for the development of knowledge. So we want to skew more towards the intervention side, and then you'll see a link at the bottom of this slide that points you, and this link is also available on our FAQ. I think that this webpage does a really great job of differentiating between the two. And then, so again, we are skewing more towards the side of quality improvement intervention. So let's move on from eligibility to the the 3 categories for the Sea Grant program. So the 3 categories are still the same. So there are the big 3 conditions: vascular events, infections, and cancers, as defined in Dr. David Newman-Toker's paper. Also, the second category is diagnostic quality disparities, and then the third category is interventions that do not fall in either of the 2. This year, we have a increased focus on diagnostic quality disparities. So if you remember from last year, the proportion of awards was 50% big 3, 40% diagnostic quality disparities, and 20. This year it is 40, 40, 20. And so with regards to diagnostic quality disparities, we have resources that on the FAQ that refer to the foundational readings on disparities in diagnosis on our webpage. And I highly recommend that you check this page out if you have not done so already, because it provides a lot of peer-reviewed literature around the area of diagnostic quality disparities. And even if you're new to diagnostic quality, there is a diagnostic quality 101 kind of thing. It's kind of the baseline readings that you should make yourself aware of. So we should also, I also want to bring up the fact that applicants can focus on settings that primarily serve vulnerable populations, and we were thinking FQHCs, community health centers, or safety net hospitals. So within the application process, we will look a little more favorably on those types of applications, since this is a focus area. And then also proposals that meet both the criteria for the big 3 and diagnostic disparities will also tilt the scales a little more favorably for you. So let's move on to the application required components itself. And there, as many of you who have already logged on, and we can see who has logged on, there's an online application that includes a simple budget. There are letters of support, and then the bibliography. I'll only highlight certain elements of the budget and the letter of support here, but if the rest of the elements are pretty straightforward. So with regards to the budget, as I mentioned, it is a simple budget, and these are the components contained. It's personnel, materials, travel, and indirects, and there is a limit of 12.5%. We're capping it at 12.5% for the indirect costs of your budget, but the maximum limit for the award is $50,000. So it has to be within that $50,000 range. What specifically won't we fund? So we do receive a lot of questions about what we will fund and not fund. So major capital expenses. So for example, if you submit an application that is $50,000 worth of medical equipment, that we will not look very favorable on that proposal, right? So but we will. So I hate to say this, but it does kind of depend. If you can make the case that the equipment supports the performance improvement activity or project, then we will, that is something we can consider. We will also not fund sub-grants. So if you use the $50,000 to provide grants to other organizations, and then of course travel to other conferences. But there is a requirement for travel and attendance to our annual conference. So let me cover some aspects of the letter of support. This is a slight change. There is a slight change from last year's application. So if you're reapplying for this year, we put more of a focus on the letter of support. And I want you can look through the different criteria here, but we want to stress that failure to attest to all 7 points could be grounds for disqualification. And why do we find this very important? Because the leadership support necessary to get the project up and running or implemented is challenging, and we need that kind of assurance up front, especially with regards to number 6, data necessary for project completion. And so, if you're developing an intervention that is completely dependent on data, and and you're running through an experience with, as we are today with the pandemic, where some organizations are experiencing a hiring freeze, and so you can't hire that data analyst. Having that assurance up front will help mitigate some of the risks later on for the success and failure of the grant. So let me pass it on to my colleague Jan, who will cover the application. And I think I scrolled through 2 slides. There you go. There you go.
Well, thank you, Jerry, and hello, everyone. The screenshot that you're seeing here is on this slide is taken from the DxQI seed grant landing page on the CITM website. It provides a nice way to access the information needed for this grant application. Jerry has already covered the program requirements and what we are looking for. So the next few slides will provide an overview of what is being requested in the application and how that translates into the evaluation of the grant proposal by the judges. Next slide. The first section of the application and the scoring rubric addresses aims, background, and approach. The aim statement should describe what you want to accomplish in the 12-month time frame for this grant period. In other words, what is the desired outcome for your intervention? Generally in QI, there are perhaps maybe only 1 or 2 aims, and they should demonstrate all 5 SMART attributes. So I'm going to give you a real simple, basic example of an aim statement. Over the course of the next 12 months, through a structured exercise and nutrition plan, my husband will lose 15 pounds. Specific, measurable, attainable, realistic, and timely. The judges, the judges want to see a specific aim for each step of your project plan. Those are milestones, and you will have the opportunity to provide that information in a different section of the application. I want to emphasize the attribute measurable. This refers to some type of quantitative goal, as in the example I just gave. If you need assistance in writing your aims, the FAQ provide a link to the IHI Science of Improvement Setting Aims document, which provides tips and contains a number of examples to help you. The next part of this section is in defining the background, problem and background. You will have an opportunity to describe the problem you are looking to address and why you chose this issue. Provide background, describe magnitude, both locally and nationally. You want to establish its importance and relevance to the diagnostic process. The judges will be looking for that. And you will also need to provide literature citations to support the significance of the problem. And the third part of this section is the intervention and rationale. This is where you will have the opportunity in the narrative to describe your intended chosen intervention or tool that you're going to develop and or test. You want to be able to describe how well the proposed intervention addresses the problem's root causes. Include the ability to sustain this process change over time, indicate whether it can be scaled to other populations, settings, and organizations. If you are addressing the big 3 and or disparities, this will be the opportunity for you in this section to describe how your intervention will specifically impact those focus areas. Next slide. The project plan. This is a very important part of the application. This is where you will provide a detailed description of how you plan to accomplish your aims. Begin by defining the population that will be included in your intervention. The judges will be making sure that it is inconsistent with your aims as part of their evaluation. Describe the change methodology you plan to use. Is it PDSA, Lean, DMAIC, or one of the ISO 9000 family products? This is the section where you will have the opportunity now to list your milestones and provide a timeline for achieving each. Your measurement strategy is also an important part of this section, both quantitative and qualitative if applicable. And the judges will be looking to see that it is appropriate for evaluating your desired outcome. Identify the operational resources you will need. I can't emphasize enough how important it is that you give serious thought to this aspect of your application. As part of your measurement strategy, you need to provide narrative as to how describing the process for obtaining necessary data to determine improvement. Ask yourself this question: is the data already being collected and reported in a manner that will enable me to analyze it for my purposes or not? If the answer to your question is not, you will need to describe your plan for obtaining the necessary data. Does a data collection process or system still need to be built or installed? Who will collect that data and how will it be retrieved? If fields need to be added to your EMR or some other IT program, how will that get done and by whom? Just keep in mind that data in does not necessarily translate into information out, especially usable information. Next slide. The third section of the application and scoring rubric addresses organizational rationale. This is where you will input the names, roles, and qualifications of your core team. The judges will be evaluating whether it is interdisciplinary with appropriate stakeholders involved to accomplish your aims, including patient family representatives. They will be looking to see how well the team makeup aligns with your aims and your ability to accomplish them. And you want to be sure to have a member on your team or a key stakeholder who brings the QI, PI, change management expertise to the group to guide the team through the project plan. Next slide. The fourth section is risk and risk mitigation. Your team needs to give thought to what potential negative, unintended consequences could result from your intervention and establish balancing measures that will be put into place to determine whether negative consequences have occurred. All projects will experience challenges or run into barriers along the way. I think last year at this time, no one would have expected the impact that coronavirus has had not only on our institutions, our country, but the world. So projects are more likely to be successful if those challenges and barriers are identified and a plan developed to mitigate those events should they occur. Regardless of whether you are dealing with a pandemic, things like the inability to obtain needed resources, hiring freezes, IRB hurdles, competing time demands will still occur. And so again, how will you plan for those if they happen? If your intervention will require committed IT time. So for example, you are going to develop some kind of clinical decision support tool, develop an AI platform, or even if you just plan to develop some type of electronic checklist or dashboard, you need to keep in mind that IT priorities may not be your priorities. Things come up all the time that redirect IT resources to other projects, departments, and services. And finally, the judges are going to have the opportunity in a free text field to provide comments on the application. They're going to give their thoughts as to how feasible, sustainable, scalable, and spreadable the intervention can be across settings and organizations, and whether the overall proposal is consistent with the intent of the SEEK grant program. So thank you, and with that, I'll turn it over to Sue Schrant.
Great, thanks so much, Jan, and good afternoon or morning, everyone. It's my pleasure to talk to you about what we think is a really important component of the SEED grant program, and that's patient and family engagement. At CITM, we believe that patients and families have a truly critical role to play in improving diagnosis, and so you will be asked to explain how patients or families will be involved, or maybe already have been involved in the work that you're proposing. We understand that there may be project ideas that don't seem to lend themselves well to patient or family engagement. And so if you believe that that's the case, we just ask you to walk through that rationale in your proposal. Help us understand why engaging patients or families is not thought to be beneficial, or maybe just not thought to be feasible. So we can go to the next slide, please. But before we kind of dive into those submission details, let's just take a step back and get oriented to this concept of patient engagement. I think one of the reasons this can be a challenging area is that the term patient engagement or patient and family engagement has been used in so many contexts and intended to mean many, many different things. So just to ground you, for the purposes of the SEED grant, you can think of patient engagement as really two types of activities, two bodies of activities. The first, which is certainly the most well-known, is the idea that patients and families who are empowered and supported to be active partners in their own care, and in this case, in their own diagnostic processes, tend to do better and feel better. And as such, they should be looked to as key members of the diagnostic and care team and involved in decision-making and goal setting. So that's the first type. The other type of patient engagement focuses not on a particular patient or family's own care or their own diagnostic journey or clinical management, but rather on drawing from the lived experience of patients and families who serve as partners or advisors in the improvement and the design of the healthcare system that serves them. So in quality improvement, this would mean partnering with patients and families in the planning, development, evaluation of QI interventions whenever possible. And in the second type, patients can take on just about any conceivable role. So they can co-create the plan for the project, they can help with troubleshooting issues like recruitment of participants, they can co-design materials, and then they can even assist with data collection and data analysis. So we can go to the next slide. To kind of flesh this all out a little bit, let's just use a hypothetical example. In this case, maybe a project focused on making sure patients follow up with further or additional diagnostic testing. And clearly, if someone's putting forward this idea, those clinicians, researchers, QI experts would have specific reasons for wanting to do a project in this focus area. It would likely be based on what they see and experience in their daily work. They would have ideas for how the project might be able to help the issue, maybe something like a new alert or a reminder system, some kind of communication tool. And so they'd have an idea of how they'd want to launch and run the project. But really, for any project that will ultimately touch or impact or involve patients and families, patients and families can serve as valuable partners. So if we advance to the first block of text, great, thanks, Jerry. Even at the very beginning, when you're first ideating, you could work with patient or family partners or advisors to just better understand the issue from their perspective. And so in this case, they could share their own experiences with barriers to follow up, what might have helped them with those barriers. And they can give specific feedback about what the proposed idea is. So here again, if the example is to increase the number of alerts or communication to the patients to remind them to schedule the diagnostic test, what if you heard from your patient advisors that transportation was actually a really big barrier? Maybe then the alert could include information about where to go to get help with transportation, somehow being responsive to those other barrier needs that the patients identify. You can advance to the next step. As you're creating the plan for the project, the patient and family partners and advisors can continue to help shape the work. Having them help with patient-facing materials is almost a no-brainer. They always have a great feel for what can be understood and come across well to any patient participants. But they can even be involved in much more technical ways. So here again, going back to our hypothetical, if we're building out a tool for communication, maybe the patient advisors would want to make sure there's sort of maximum flexibility. So we'd want the tool to be via email, via text, via patient portal, multiple options so that the patients have sort of choice and flexibility in how the tool works. And then finally, if we look at the last step, when the project is up and running, patient engagement continues to be important. And now you're really looking at both types of patient engagement. You've got the patients who are actually participating in the project at the clinical sites. So they're being engaged by the clinical team. They're using this piloted tool or piloted process. But you still have your patient and family partners or advisors on your team. Again, helping to troubleshoot, that's always a key role. But they can also help with data capture, data analysis. And in a project like this, for example, if you're seeing trends in uptake and responsiveness to the tool, to the communication, often patient partners can offer some insights from their lived experience that are going to be pretty unique to those of the clinical team. So if you had a cohort of older patients, let's say, that seem to just not be very responsive, your patient partners might be able to shed light on issues around technical savviness, and are they not hearing the alert? Is there some technical barrier? Maybe if it's a young cohort of female patients who seems to be particularly unresponsive, patient partners might offer things like, well, how many of those women are young moms with kids at home, especially in COVID? Or are they new moms and feeling overwhelmed? Maybe if there's a dip in responsiveness when you're looking at the calendar year, patient partners would offer something like, well, that's because in January, everyone's insurance plan reboots and they don't have HSA money to cover out-of-pocket costs for diagnostic testing. So there's all these sort of contextual factors that the patient and family partners can provide to really help unearth those themes and those trends in the data. So as you're preparing your submission, you just want to think about it just as we just did, in sort of that stepwise way, how you're going to work with patient or family partners or advisors on your team to develop the idea, plan the project, execute, evaluate the project, but then also how are the patients at the clinical site going to be engaged in the project itself. So with that, I'll turn it back over to Jerry and Jan for the next part of the webinar. Thanks so much.
Thanks for that, Suze. So what I want to cover are just some other considerations as you go through the application process. So the first point is that we need you to confirm that there is no additional external funding to do this work. So these are not intended to be small parts of a large research effort, or it's not intended to take the place of existing funding for you to do your work. The second point is that we have it highlighted here, we want you to ensure that the IRB is aware of the proposed project. Even though this is if it falls in the bucket of traditional QI, it does not require IRB approval. Sometimes you need to go through an IRB waiver process, or sometimes there is some sort of approval process that you still need to go through. So ideally, all of the IRB issues are resolved as you go through the application process, and you will not receive funding until any and all IRB issues are resolved. So the other consideration is that once funded, grantees are expected to attend a cohort kickoff webinar, submit bi-monthly reports, so that's every other month, and the bi-monthly reports are not intended to be very time-consuming. They are just intended to be more status checks. There are formal mid-project and year-end reports, which do follow the traditional report out on where you are and with regards to the aims and deliverables. So that will be only 2 of them. We have an expectation where you participate in quarterly calls to facilitate a quality improvement collaborative amongst the cohort of grantees, so that you can support each other, share ideas, and advance your work together. Similarly, with the online community, there is an online discussion board where you can share resources, articles, or just report out on other activities that you are engaged in. And then we have a requirement where grantees are to attend 2 designated QI summits that coincide with a future CITM annual meeting. The review process is in stages. So there's a technical review process where we ensure that the proposals meet the inclusion criteria or meet the intent of the grant. And then there are subsequent rounds of peer review and a final, which includes, I should say, a specific patient engagement review, and then a final review by our grant review committee at an in-person meeting. It says here all applicants will be notified of a decision by June 1st, 2021, but right now that's our target. So for example, last year we extended the deadline for applicants, so that naturally extended the notification deadline. So we are shooting for June 1st. These are the resources that I mentioned that are available online. So there is the RFP, the FAQ, and the specific instructions for the online application tool. And again, those are available via our website, and that is the website up there. And then, so let me pass it on to Jan for some proposal writing tips.
Okay. Thank you again, Jerry. With this being the second cycle in the SEED grant program, we learned some things from the first cycle of applications and have compiled this list of tips. First of all, develop a quality application. Many of you have done grant writing before, but I want to encourage you not to just copy and paste into this application. You do need to read and answer what is being asked as clearly as possible. The judges need to be able to understand from your narrative what you intend to do, why, and how you plan to do it. And keep in mind, they are not familiar with your organization, so be careful using acronyms or terms or things that are very institutional specific. Try to be clear and concise in your narrative so that they can understand what you are attempting to describe. The step-by-step guide and the FAQs that Jerry just referenced need to be read and referenced as you prepare your application. CIDM has made every reasonable effort to be as transparent as possible about what is expected for each question and how it will be scored. And I hesitate having to say this, but if we didn't have the experience, I wouldn't. You need to use good grammar, spelling, and punctuation. This next point, I have to tell you, I struggled with how to say this diplomatically, so I'm just going to have to say it straight up. The grant is not intended to subsidize people to do the job that they were hired to do, to acquire medical equipment that did not get approved in your capital budget, or to simply hire more help for your workplace. I also want you to remember the attainable and realistic attributes to the SMART aims in developing your goals and intervention. Keep in mind, again, that this is a 12-month grant project. So, and don't try to solve world hunger. You really need to be able to keep it attainable and realistic. Finally, CIDM will not be providing training on how to write grants for those of you who may be new to this process. But if you are new and you could use some assistance, there are lots of resources and training programs available on the internet. And here are a couple of resources that you might consider that can help you with that. Jerry, back to you.
Okay, great, thanks for that. And so here are the important dates. The application deadline is March 25th, so that is coming up. So if you're like me, don't procrastinate. Don't procrastinate. Try and log on to the online application site if you have not done so already, and start filling things out. And then, of course, getting the necessary approvals. Again, the award announcement date is June 1st. We are shooting for June 1st, and then awarding the grants along that time. So the grant period will be June 2021 to June 2022. So let's move on to the questions. So a number of you have submitted questions online in advance. So we will answer those questions in the order that we receive them. We may not get to all of your questions, but we will post the answers online for you. So let me start with the first question that we received, and then Jen and I will be tag teaming on these questions. You mentioned in the FAQ that grant funding shall not be used for major capital expenses, but what about other equipment necessary to complete a project, such as a portable ultrasound device, small items? So again, it depends. So we can kind of tell whether or not a proposal is just submitted for capital expenditures, but if it is a equipment that will support your intervention, and that's really what we need to see demonstrate within your proposal, that it is equipment that is necessary for the intervention, and you would need to justify why, and then keep that into consideration that you know, this will be judged relative to other proposals as well. So you know, how that will affect the judging is something that you will have to determine for yourself. So let me pass it on to Jan for the second question.
Okay, just a second here. The second question is that we mentioned in the FAQ that grant funding should not be used. Oh, sorry, that's the wrong one. I think we've already answered this in the chat, but the question was, are the bi-monthly reports due twice a month or every other month? Every other month.
Yep. Okay, very good. Very good. And I do see that was a question in the chat also. So the next question, our project aims to address diagnostic error by improving provider-patient communication. Great. As such, it isn't targeted toward any one area of improvement, but should impact the big three, health disparities, and other areas. Do you recommend that we attempt to target it to only one area or submit in all three? Okay. So you do have the opportunity to select both big three and disparities in the application, but you will definitely need to describe in the intervention and rationale section how your intervention will specifically impact these areas. So, you know, some things you could do to meet these criteria are limiting the sample by those categories, or including the ability to stratify the results based on those criteria. So kind of segmenting your samples or dividing them up into subsets and groups. Okay, next question.
Okay. The next question asks, relating to the 4 categories of intervention, our intervention is defined but needs resources to build it out before it can be tested. Do you recommend we submit in the first category and use the discovery period to build out the intervention, or would the second category make more sense? And that has to go with that earlier on in the webinar when Jerry pointed out those 4 categories. If the intervention has been defined, you would still need to address the time needed for build out, and we're not really sure exactly what you mean by resources to build out, so that would have to be explained in more detail. But you need to consider that this is just a 1-year project, and so the first 6 months can be used for discovery or development, but the second 6 months needs to show that several testing cycles have taken place with your intervention. There's data collection going on, that sort of thing. So you really need to be cognizant of the time. The entire 12-month period cannot be spent just on discovery. Mm-hmm. Okay. And build up. Yeah. Okay.
The next question is, if contracted services are included in our budget, does CIDM have any requirements of how contractors are selected, or is that at your discretion? So we don't have any requirements for contractor selection. However, since this is considered a third party, you will need to address that within the body of your proposal, and then also have them submit a letter of support. Okay. Next question.
Yes, hold on a second. I gotta hold it up here. Okay. Will there be grant writing coaches from whom we can seek advice from as we develop our proposals? Is preliminary data required for the proposal? It's actually a series of questions. Can the budget be used for indirects or only for directs? Can the budget support PI or personnel time, or is it only for materials? So I think we've covered a lot of this already. As we said, we are not providing grant writing assistance, but it's available to you. There is no preliminary data required for the proposal. We have already talked about indirects, and personnel time. So I think those answers have, those questions have already been answered in the program.
Mm-hmm. Okay. And so there was a question about, can we submit
Jerry, can I just supplement Jan's answer?
Please go ahead.
So the question said preliminary data, and Jan said preliminary data isn't required. I think you still have to, and it asks for it in the application, show evidence that it's a problem. And whatever evidence you may have, it may come from literature, it may come from other places, but you do have to address that it's a problem, that there is a burden. You don't have to actually run a test cycle to collect data. And I just wanted to clarify that.
And we don't ask for that in the application itself. It's not a specific question in the application, but I think you're right. Thank you, Paul, for clarifying that.
Okay, so the next question is, can we submit a project scope for more than $50,000 and supplement from another source? If yes, how would you like that reflected in the budget? And I think I may have seen something along those lines in the chat too, but I may be wrong. So the budget should describe what you will use this particular grant award for and in what amounts. And so what we mean by that is that we are most interested in what you're going to do with the $50,000. But within your proposal, you can also describe within what context that you will be spending this money on. So if it's in the context of other activities around diagnostic quality improvement, please do describe that. I think that will be helpful in understanding the context of where you're operating in, what you're trying to accomplish. But you know, specifically as far as whether or not you enter that data into our budget, please don't. It'll just confuse us, and I think it'll confuse the software, since there are actual number limits in the values that you are able to enter in there.
And Jerry, you did say earlier that we're not trying to be a small part of a big research. So really, I think it was in the slides, we don't want to see external funding going into this. It's, of course, if there's in-kind funding from within the organization, that's fine. But we're not looking to this to be matched with other funding sources externally.
Great.
Okay, the next question, is the grant mechanism more interested in underdiagnosis and misdiagnosis than on overdiagnosis? Would overdiagnosis count as an area of concern? That's a kind of a tricky question to answer, because it all really comes down to the fact that this grant is intended to support improvement in diagnostic safety. So if that question is more around utilization of resources and the financial implications of utilization, that's not where we're headed. This is really about looking at significant cause of preventable harm due to diagnostic errors. And so again, it gets back to how is that tied into accuracy, timeliness, and communication. And Paul, do you want to add anything to that?
Well, just simply that when people use the word overdiagnosis, I hear different things. There's people who overtreat. They get an accurate diagnosis, and they treat on that accurate diagnosis, and maybe they shouldn't have treated. Maybe they should have monitored. Not every PSA that's elevated requires surgery. That might be overdiagnosis. And so we don't want to get into misdiagnosis being called overdiagnosis or overtreatment, people acting upon diagnostic, accurate diagnoses, but just being too aggressive. So there's probably the issue of overdiagnosis is probably a little narrower than this question might have implied. There is some overdiagnosis, and certainly that is a valid area. It's just not typically the issue we're trying to address.
Very good. Thanks for that. So the next question was, the bulk of our budget would be allocated to a patient navigator position who will run the day-to-day duties of our pilot program, database entry, email, and phone interactions. Funding for this position, which is fundamental to our program, is the reason for our grant proposal. Is such a position considered an indirect cost, limited to 12.5%, or direct costs? In this particular instance, it would be considered a direct cost because it is, as the question mentions, it is fundamental to the intervention itself. So, next question.
Okay. I wanted some clarification on the question, will the required data be readily accessible at the time of implementation? Would you be able to give case examples in which data is readily available versus not? It is not quite clear in my mind what is meant by the required data. We've spent a lot of time in the webinar addressing that particular issue of data accessibility, and I hope that we have answered your questions about that. You know, that it's been a particular problem with this first grant cycle just because of the way so many institutions have redirected those resources to addressing the coronavirus issues in their organizations. But accessibility does refer to the project team being able to access data needed for the project and to be able to evaluate whether the goal of your aim is being met. So, for example, as a clinician, you can readily access your patient's EMR data. However, if your project requires IT intervention to pull that data from disparate sources for a clinical decision support tool, then the required data is not readily available. Another example is that if you have to create EMR fields or some other electronic tool to capture input data, as well as to develop reports to analyze that data, then it's not readily available. Mm-hmm. So I hope that we've been able to answer that question both through the presentation as well as in this Q&A.
Mm-hmm. All right, next question. Please clarify the details around member obligations. Member organizations are asked to attend 2 annual QI summits and CIDM annual conference. First, is this a total of 2 conferences and 2 annual QI summits and a CIDM conference? What is the time commitment for these conferences? What is the time commitment for the online community work? So the annual QI Summit is intended to be a meeting of grantees to occur in conjunction with the CIDM annual meeting. The annual meeting is usually 2 or 3 days. We expect engagement and participation in the online community, as I mentioned before, to foster QI collaborative. So and of course, due to the coronavirus pandemic, we have had, especially for the first cohort, using them as an example, we have had to move the annual conference to a virtual, so there was no travel associated with that. So this year's conference is going to be virtual also, and it is going to be 3 days. And it is, it's expected to be 2.5 days. Okay, I'm getting confused. Start over. So this year's conference, 2021, okay, is going to be virtual. It is going to be 3 days. So you do not need to budget travel costs for that conference. However, you do need to budget travel costs for the conference in 2022, which is expected to be 2.5 days and in person. So, sorry, I hope I did not confuse that question.
And by the way, 2022 will be in Minneapolis.
Thank you for that.
From a travel perspective.
All right, next question.
All right, thank you for releasing this RFP. I am a clinical researcher and unfortunately will not be able to attend the webinar on Wednesday. However, I do have a question about whether our project idea would fit with the scope priorities of this RFP. Our clinic sees individuals with high risk to develop cancer based on their family history or genetic predispositions. We provide initial risk assessments to determine risk level. Patients at increased risk are then either followed by our high-risk clinics annually or receive care locally with their providers if they reside in more rural, remote locations. We'd like to evaluate whether any discrepancy exists for access to appropriate surveillance and risk reduction that high-risk individuals between these 2 groups, those seen at the center and those followed locally by their own providers. The goal is to do a QA and then address any discrepancies and create mechanisms to increase access to these clinical services if needed. Okay, I think this question, rather long and detailed, relates to one that we had earlier, and that is, they're looking to have a discovery period where they determine just the impact, how much of a problem they have, what the variance is, and then we'll define an intervention to try to address things. And it gets back to the fact that we're looking at a 12-month period. If you have a discovery period, the maximum for that is 6 months, and then the intervention period needs to follow, where your intervention will be tested through through several cycles and improvement noted. Jerry, Paul, either of you want to comment on that anymore?
First thing, thanks, Jan, and I do think in general, we do not want to give opinions on specific cases but I think this is illustrative, and that's why Jan chose to address it. The issue, we've talked a couple times about discovery periods, but this is not intended to be a discovery grant. So one of the things the grant proposal will be judged on is what happens if we get to the end of a 6-month discovery period and there is no intervention that emerges, and therefore there is no quality improvement going on. So the dependence on a discovery period without any speculation about what the intervention will be will probably not be judged highly. If the discovery is to try to get nuances of the problem to help shape the intervention before actually implementing it, that makes sense. If you're going on a fishing expedition and you don't know what the intervention is going to look like, then I'd say it's unlikely it would get funded.
Okay. All right. Oh, and we are coming up to time, so
yeah,
I think we can.
Close to out of time.
We are. So, but I think I can answer one more question. So this question is, which project personnel are expected to attend quarterly calls, the online community, QI summits, and annual CITM conferences? So it's actually up to you, to the organization, to decide which members of the team to engage in and participate in the various activities. Obviously everybody's busy, and it's tough to participate in a lot of these things, but the way that we've seen the first cohort approaches is to use a team approach. So essentially to divide and conquer. Many of the, in addition to the PI, many of the team for the proposal decided to attend the annual conference just because they found the experience to be valuable. Same with the communities and the other resources. So it's really up to you to determine. Okay, and we have 1 minute left, so I will pass it off to Paul for our concluding remarks.
Thanks. So we really only got through the submitted questions, but rest assured that every question put in the chat will be answered. We will post the answers to the submitted questions, pre-submitted, and also the ones here. Part of the transparency is making sure that everyone has access to the same information, that there are no insider information being given to a single person. So we will not respond to you individually. We will post to the website the questions and answers. Again, the goal, remember, is to work on a improvement project, not a research project. If you just set controlled variables and study for 1 year, that's research. The notion of being informal and going through cycles and trying new things to learn, that's the kind of project we really wish to support. And with the question about disparities, you can analyze data using a disparities lens, One of the things that we know is it's tough to measure diagnostic error, but it is easier to see the differences in diagnostic outcomes between populations. And then we believe in something called the curb cut effect, which just basically says you can do something for one purpose, but it has spillover benefit. And we think the learnings that will come, whether it's based on the big three or disparities, will ultimately have utility for everyone trying to improve diagnosis. Thank you so much for your participation. And again, we look forward to working with you and love to see your applications come in. And thanks to the people on the speakers for the information they shared. I think we're adjourned. Thank you.
Very good. Thank you.